This recording is going to cover pulmonary ventilation, which is the physical act of moving air into and out of the lungs. This is the second part of recordings that are covering the respiratory system. Now remember that the function of the respiratory system, or I should say one of the functions, is actually to get cells supplied with oxygen and remove carbon dioxide, which does require the process of getting air into and out of your lungs, which is pulmonary ventilation, as well as external and internal respiration. Now, the basis behind pulmonary ventilation is provided by a certain law referred to as Boyles Law. And so I kind of want to discuss, before we kind of look at what this picture is depicting, is I want to talk to you a little bit about gases. Now, in a gas, molecules move around, it's just independent entities, and you see here's a gas molecule here and here's one here. And at atmospheric pressures, the gas molecules are much further apart than you see within a liquid, so the density of the air is relatively low. And the forces that act between the molecules are relatively small, so if you apply a pressure, you can push them closer together. Now, the pressure exerted by the gas molecules, like you see enclosed here in this container, they result from the collision of those molecules against the walls of the container. And the greater the number of collisions, the greater the pressure. Well, what we can do is we can change the pressure within a sealed container by giving the gas molecules either more or less room to bounce around. So if you notice here, if I decrease the volume of the container, so I push this down and I've decreased the volume of the container by half, you notice I've increased the pressure. So Boyles Law shows us that gas pressure is inversely proportional to volume. If I actually increase the volume of that container, the gas molecules would have much more room to roam around, and pressures would actually decrease. And so the movement of air into and out of their lungs is actually based on pressure differences. And air is always going to move from a higher pressure to a lower pressure. And what we can do is we can move air into and out of our lungs by creating pressure gradients. And we do that by changing the volume of the lungs. And then we're going to use that to our advantage. We're going to start here with, you just finished breathing. And the diaphragm, which is a very important skeletal muscle involved in breathing, is relaxed. You see it's like dome-shaped here. Your other muscles associated with the thoracic wall are relaxed. And we have no airflow because the pressure outside is the same as pressure inside. So as a reference, I'm going to use atmospheric pressure as 0. And pressure in here is 0. Okay, so I'm going to use little a for alveolar pressure and big A for atmospheric pressure. They're the same. There's no air movement. Inhalation is an active process. So we have to have the nervous system, the somatic nervous system, needs to tell the muscles of inspiration to contract. In normal breathing, it involves the diaphragm, which you see here, and external intercostal muscles, which we find between the ribs. And what's going to happen is the phrenic nerve will stimulate the diaphragm to contract. The intercostal nerves will stimulate the external intercostals to contract. And so what you'll notice is what happens is the diaphragm flattens out, the thoracic wall expands, and as a result, the volume of the thoracic cavity is going to increase. And because of Boyles Law, if that denominator gets bigger, the pressure is going to get smaller. And so alveolar pressure is going to drop, and it's going to be less than atmospheric pressure. So atmospheric pressure is still 0, but alveolar pressure is, say, -1. This is where if you see the term negative pressure breathing comes into play. In order to inhale, the pressure in the lungs has to be less than atmospheric pressure. And so it's less than atmospheric pressure, so air will move into the lungs. Now what's aided, I do have to mention what's aided, what you see here is pleural membranes. You have the parietal pleura, which lines the cavity in which the lungs are found, and you have the visceral pleura, which is attached to the lungs. And you have that little bit of serous fluid between them. And it's kind of like this glass slide scenario. If you ever took glass slides and wet them, they'll stick together, and it's hard to pull them apart, but they can slide. You can slide them across one another. And so what happens is when this comes out, because of contraction of those external intercostals, the lungs come along for the ride. So in other words, the thoracic the cage expands, the parietal pleura gets pulled out, the visceral pleura expands, and the lungs expand. So that's what happens. Now, if I want even more air to come in my lungs, I would actually have to increase that volume of the thoracic cavity even more, and I would have to use, say, the sternocleidomastoid, the scalenes, the pectoralis minor, the serratus anterior. Those would contract, and you'd be able to get that volume of the thoracic cavity even greater to drop that pressure even more so I can get even more air into my lungs. Now, what happens for exhalation? So what happens is the firing of those nerves to those muscles stops. The muscles are no longer to contract, they're going to relax. Plus, when you have those muscles relax and you have stretched out those elastic components associated with the lungs, like all these little elastin fibers that you see here, they're going to want to go back to the original position. You do have something called the inward pull of surface tension because we have a little bit layer of fluid that lines the wall of the alveoli, and that's going to lead to expiration. Now, expiration, resting expiration, or exhalation, same thing, exhalation and expiration, is passive. You don't need nervous input for this to happen. So what's going to happen as all the muscles relax and you got all that elastic recoil of tissues, the inward pull of surface tension, the volume of the thoracic cavity is now going to decrease. And a result of that, again, because of this equation, alveolar pressures are going to increase. So now pressures in the lungs is greater than outside. And so, say here, this is 0, air will now move out of the lungs. Now, if I want to get even more air out of my lungs, I'll have to use some muscles to do that. And now when I'm doing forced exhalation, it will now become an active process. And so I would have to utilize, say, for example, your abdominal muscles, your internal intercostal muscles. They will compress that thorax and will be able to move more air out of the lungs. Now, something I do want to mention, and I'm going to come back to this picture here. So when I'm inhaling, as air molecules are going into the lungs, more and more air molecules go in the lungs, pressures are going to start to increase. And as pressures get to the point where they're the same as atmospheric pressure, you're going to stop inhaling. So when they're the equal, because the air molecules have come into the lungs. Same way applies with that exhalation, is as you're exhaling and the air molecules are leaving the lungs, pressures in the lungs are going to drop. And again, once they're equal, you're going to stop exhaling. Okay, so that's what happens. Now, I do want to mention a concept called compliance, and specifically lung compliance. Compliance is equal to a given change in volume over a given change in pressure. Now, this is a concept we can apply. We can talk about vascular compliance. We're talking about blood vessels, but here we're talking about the lungs. But similar thing is, for a given change in pressure, how much volume can we get into the lungs? And your lungs are fairly compliant. Now, think of this compliance as a degree of expandability of the lungs. Now, the lower the compliance, the greater the force it would be required to fill and empty your lungs. And a reduction in compliance would really affect the amount of energy that you would need for breathing. And compliance can be affected by levels of surfactant, could be affected by connective tissue structure of your lungs, and certain musculoskeletal disorders can also affect compliance. So I'm going to give you a couple examples on how they affect compliance. So two things that could actually increase lung compliance: emphysema and aging. You're like, well, that's a pretty good thing. So if I increase compliance for a given change in pressure, I can get a lot of air into my lungs. Yeah, you could. But the thing is, with an increase in compliance, you're going to have a hard time getting air out of the lungs. That's where the problem is going to be. And what happens with emphysema, this is a loss of elastin fibers. Now, if something's elastic, you're like, oh, it expands. No, it doesn't. It wants to keep its shape. So if you lose elastin fibers, there's no problem getting air into your lungs. The problem is you've lost that elastin fibers, which contributes a great deal to normal expiration, so you don't have to work to exhale. It's going to be hard to get the air out of your lungs. Aging, as you get older, we do start losing elastin fibers too, and so that's also associated with an increase in lung compliance. Emphysema obviously is a lot more. Now, things that could affect decreased lung compliance is musculoskeletal disorders like lordosis and kyphosis and scoliosis. So lordosis, you have that exaggerated curve in your lumbar spine. Kyphosis, you have that exaggerated curve up in your thoracic area. Scoliosis is kind of where you have, if I look in the back, you have the S shape for your spine. That's scoliosis. All those can affect your ability to get air into your lungs. With restrictive lung disorders like tuberculosis or fibrosis, they can lead to scar tissue development, which would make it hard to get air into your lungs. So with disorders that decrease lung compliance, it's going to be very difficult to get air into your lungs. You spend a lot of energy inhaling. Now, increasing lung compliance, the problem is getting air out of your lungs. So neither of them are good. You don't want too high of a lung compliance, and you actually don't want too low of a lung compliance.